My first proposal was and let's go back. So we will talk about that particular article, and then I'll tell you what might have happened ever since we published that paper. And then we can talk about more current issues that are dominating the airwaves in Kenya. And then we can conclude with an overall discussion. Next. So my thesis is that community pharmacy is the face of pharmacy, and therefore it has to be strengthened. And in Kenya, we particularly need to do this because currently community pharmacy is dominated by non-pharmacists. It's dominated by pharmacy technicians. We need to make sure that it's pharmacists who are being seen in community pharmacy because they represent the face of pharmacy. Number two, we need to shift the attention of the consumer from the pharmacy to the pharmacist. And we have to make it clear that pharmacy is a lot more than selling, and that pharmacists as professionals are interested in serving the patient and in safeguarding the safety of that patient. Now, for pharmacists to succeed, they need to have relationships with clients, and the profession needs to be integrated into the health system. Next. Next. So I made 5 proposals. The first one is that we should abolish free services. 2, we should institute a professional outlook for pharmacists and pharmacy practice in community pharmacy. And 3, we should allow part-time practice. And 4, we should restore the rule of order, the rule of law. And lastly, we should explore how we can finance community pharmacy services. Now, specifically, let's go back. My concerns about free service is that, number one, the consultation fee is an important element of the professional contract. So when you don't charge, you're actually diminishing your professional responsibility to your client. And number two, free services are likely to be perceived as inferior. And 3, offering free services is just as bad as undercutting other professionals who charge for that service. And 4, when a client accepts your free advice, they feel pressured to purchase the product from you. And 5, when you are the person who is relying mostly on the sale of a product, you cannot be expected to be objective in the advice you provide. So it's important that we do away with free consultation services. The next one is about our professional approach to the patient. I think the first thing we have to stop doing is doing what they call over-the-counter consultations. I think in our code of ethics, we have already established that we should have consultation rooms in our pharmacies, and we should be putting those rooms into use. Number 2, we should document whatever services we do, including the consultations we make, the therapeutic plans we institute, and we should start, collecting these patient medication records for prospective medication treatment management. Another thing we need to do in order to be more professional is we should stop using business names and start using our own personal natural names, because this is the practice in all other fields anyway, where people have clients. And we should stop identifying our workplaces as business premises and look at them as practice sites. Another recommendation is that we should change the way we design our pharmacy premises, our pharmacy practice sites. It is actually possible to practice pharmacy without displaying pharmaceutical products. I don't know what the thinking is behind displaying pharmaceutical products. Are you trying to induce people to buy? Because if that is the case, then you cannot be seen as a professional. Now, the other bit is that we should think about where we locate our pharmacies. Our pharmacies should be located where other professional practices are located. They're usually not located in supermarkets, fuel pump stations, in shopping malls, or places like that. They're usually located near offices. Now, this would make pharmacists more credible as healthcare professionals. Now, the other bit that I proposed is that we need to have a new financing model. And our practice has been that we usually take the product and then we put a markup on it. And then the markup becomes our profit or meets our cost, the cost of offering the service. And I think when you do things like that, you oversimplify your role as a pharmacist. We should actually have a tariff that ensures that as a professional, you're rewarded for the exact value that you add to the patient when you're dispensing the product. And I'm also thinking that it's important, if you're going to make medicines accessible to more people, that the cost of medicines should be controlled. And when you control the prices of medicine, they become less variable. And when you have an encounter with a patient, the cost of the medicine will not be the discussion you're going to have with the patient. You'll instead be discussing about what you're going to do with the medicine rather than how much you're going to sell it for. And thirdly, I think it's also important for us to think about where we locate our pharmacy practices. Currently, we locate them in the most expensive parts of town, and that pushes the cost of offering the service so high. I believe it's possible for us to think about how we can work with government so that we can offer private pharmacy services within government hospitals as amenity services. But it's possible to discuss with any other government entity about how they can make premises accessible, available for pharmacists to offer their service at, at a more modest cost. And then I think our professional societies and leadership bodies should now start thinking about how we can tap into the universal healthcare program that is currently on the national agenda. The other bit that we need to think about is how we can how we can raise our levels of compliance with the law. I think year after year, we hear how many unlicensed pharmacies we have in this country. And I think we have been looking at the wrong places for the answers. We have to start looking within ourselves for solutions to this. I think if there are unqualified people working there, they are actually supported by the qualified people because they have to sell pharmaceutical products, which come from wholesale dealers who are pharmacists. For them to work where they work, they are actually known to drug inspectors who are also fellow professionals. So we have to start thinking internally what our values are as professionals. Then the other proposal that I included in that paper is a proposal for part-time practice. And this is motivated by the following. Number one, when you look at our colleagues in, say, medicine, they grow themselves by working part-time in private practice while still working for government. That's where they build their brand. So how are pharmacists supposed to remain current with knowledge if they go into government service and they stay there without interacting with the pharmaceutical world, as it were? They need opportunities to go out there to share their knowledge and to build this new thinking in pharmacy, that pharmacy is service, not business. So they would be critical in implementing this. So what we need to do is to license part-time pharmacy practice, as is currently the case for other consultants in healthcare. Next slide. Now, one might ask, is this really feasible? And I like to say that from the outset that I know that the LSK, the Law Society of Kenya, and the Kenya Medical Practitioners and Dentists Councils have given guidelines on fees that can be charged for every possible professional service. So the LSK, they've given minimum fees, and KMPDC have maximum fees. So it's possible for us to have a tariff that says what service qualifies to be paid what amount of money. The other one is that county governments and non-governmental organizations can actually own and run pharmacies according to this new model I'm proposing. So when they run these services, they don't run to make a profit. They run the service to deliver a service, right? And as they do that, they take care of their costs and they're able to pay the pharmacist who works there and every other staff who works there. So according to our constitution, county governments are allowed to own county pharmacies. It's something we can explore. Next. I'm also aware that in Uganda, pharmacists are allowed to supervise up to 4 different pharmacy practice sites. So it is possible for one to be employed in government and have a part-time license to work elsewhere. We also need to redefine what supervision is. Supervision should not mean physical presence. We have technology to actually monitor what goes on in a pharmacy at a distance. I think supervision means accountability. So for you to prove that you are accountable for what goes on in a pharmacy, you must have a system that demonstrates that you're actually taking that accountability. It is not physical presence that is most important. What's most important is when your intervention is required, are you available? Are you able to review what everybody in that pharmacy does while you're not around, or when you're not able to attend to a client? Are you able to ensure that there are clear standard operating procedures on what is to be done and what requires your input and what doesn't require your input? If you can clarify that, would actually make pharmacists more accountable for what they do, and would not have some of these issues you're having with pharmacy, as you shall see later. Then there's also the other option of group practice, where a pharmacist will get together with other healthcare professionals and they will have a community of service providers working together. And the pharmacy will become part of that network, dispensing the medicines, supplying the advice and information as required. And then lastly, and this is also feasible, you can actually have price control. And price control is a good thing. It reduces variability and it builds trust with the consumer that you're actually genuinely interested in serving humanity. Next. Now, right now we're talking about the Social Health Insurance Fund, and I would suggest we tap into that to ensure that under SHIF, we get reimbursement for pharmacy counseling, we get money, we get payment for conducting drug use audits, supply chain audits, and vendor audits. We should also be involved in pre-qualification and monitoring of service people who provide pharmacy services under SHIF. So we need to get involved in this debate to ensure that our interests are taken care of, because this is the kind of funding model we've been looking for to support pharmacists to offer professional services. Next. Next. Now, we also need to look at the pharmacy bill that is going to be discussed. I have looked at the old bill of 2015. I think it's 2015 or 2014, and it had some nice provisions that I think we can build on. So as we continue debate on this pharmacy practice bill, let's make sure that pharmacy counseling and pharmaceutical reviews are made mandatory. Let us also ask them to include a schedule of pharmacist-only services. The law has to specify what are these services that can only be offered by a pharmacist. There is a bit on something called a professional review pharmacist. I think the scope of practice of a professional review pharmacist is inadequate and has actually been overtaken by certain events. And so I'd like us to revisit that and look at what we can do about it. The Pharmacy Practice Act should actually require pharmacists to have SOPs that detail what they do in the community pharmacy. And we can even go a step further and ask pharmacists to submit returns of what they do in the discharge of their role as the superintendents of those pharmacies. I think we should also require that government gazette practice levels and scopes of practice for both pharmacists and technicians. Next. So this is the Pharmacy Practitioners Bill 2014, Section 3, which talks about professional review pharmacist. What does he do? So it says one thing, they're involved in the initiation and conducting of pharmaceutical research and development. They're involved in the application for the registration of a medicine. And then they say they're involved in the supervision of a pharmacy. So this supervision, it is not very clear, but I am imagining it's probably going to turn out to be something like what they have in Uganda, where one pharmacist is responsible for several other pharmacies. So we need to make sure that there's enough clarity and there's enough detail so that there's enough work for that pharmacist to do, and we can actually hold him or her responsible and accountable. Next. Now, I want to say something about the KDA bill. The KDA bill is the basic problem I'm trying to address in this paper. And it's that belief that pharmacy is a business. And we have contributed to this kind of thinking as professionals. And so for as long as pharmacy is seen as to be that business that is concerned with just buying and selling medicines, other people who are not pharmacists will always demand and will probably get a share of it. So we need to go back to our mandate and our core values and commit ourselves that we are going to prove to the world that we are the best people suited to make medicines available for the people. Now, for us to do that, there has to be a change in the way we work. Next. Next. I think the first thing that pharmacists ought to do, and I hope the KDA bill will compel us to do, is that we must always be able to take responsibility, not just for patient outcomes, but also for the quality and safety of the products that we make, market, import, distribute, stock, and dispense. So it's not enough for you to be a community pharmacist and you don't know anything about good distribution practices. You have to know good distribution practices. You have to prove that you're actually practicing good distribution practices to ensure that the product is safe and is of quality. Number two, we need to design quality into the pharmaceutical services. We must think about the kind of services we are doing and plan ahead of time on how we can deliver on that quality. We have to institute quality management systems in all our practice sites, and most importantly, in community pharmacy. So when inspectors go around, they should actually be looking at this quality management system. Is it in place? Is it being followed? What are the challenges? Is it well resourced? If you can do that, then you're actually doing a more proactive thing rather than just coming to see what somebody hasn't done. Next. We have had an issue of absentee superintendents. Okay, these are people who get together with a business person and then they register a pharmacy for that person, and then the pharmacist either leaves or is kicked out or something like that.
Yeah.
So you end up with a pharmacy that has a pharmacist certificate that has been licensed by the board, but the superintendent, who is the pharmacist or pharmtech, is not there. Now, what are my recommendations about this? I think as part of licensing people to run pharmacies, the PPB, the regulator, should require that licensed applicants show proof that they have a contract from their employer or that they actually own the place if the place is theirs. And that contract should be like 18 months long so that you're sure once I give you a practice license for the year, you're able to work for a whole year without interruption. And you'll have 6 months after that to give notice to the board that you're leaving that site. The other thing I think which is very important, and I think the board will agree with me, because I've seen them doing guidelines for other areas like the pharmaceutical industry. They're specifying minimum experience requirements for people to do certain things in the pharmaceutical industry. I think it is not far-fetched for us to say that even in community pharmacy and in distributorship, we are going to have minimum experience requirements for people who want to assume the responsibility of a superintendent. And I'm suggesting at least 3 years. Once you've been licensed, you must work under somebody else, get some experience. And especially in this country now, we have a problem that people are not getting adequate internship because we don't have enough internship sites that are managed or supervised by pharmacists. So I can assure you, in terms of community pharmacy, our people are not getting enough exposure to community pharmacy. And so they shouldn't be allowed to become superintendents immediately after internship. And I think the same would apply to hospital and pretty much every other area of pharmacy. And I think once somebody has been licensed as a superintendent, the board has to be involved in removing that person from that job. Employers should not be allowed to sack people without the consent of the board. They have to go to the board and say why they want to replace the person. Similarly, the person who wants to leave that place should actually go back to the board and clearly say why they are leaving. I think that is important. Next. I think another thing we have with absentee superintendents is that many people open pharmacies, then they discover the pharmacies are not sustainable. They cannot give them enough income to sustain them. They're forced to keep their previous job or look for another job. And so they end up being absent. Now, the regulator can help us by introducing zoning of pharmacies. And I think the professional body would be willing to assist in ensuring that the distribution of pharmacies is such that it can sustain employment for pharmacists. And I think when people think about where to locate a pharmacy, they should match their location with the location of other health providers. Because as a pharmacy, you're going there to support medical practitioners and dentists. So it doesn't make sense for you to have a pharmacy where there are no medical practitioners and dentists. And I think anybody who is thinking of setting up a pharmacy, community pharmacy, should actually have linkages to the local community of hospitals and health centers for referrals. So it's important we think about how we distribute pharmacies across the country. That would ensure that these pharmacies remain sustainable. I want to say something about pharmacist training, and because I think a lot of problems come from training. And because of the problem I've told you about internship, we have inadequate internship positions for I'm told we are graduating like 500 pharmacists every year. We just don't have enough internship sites and internship preceptors for all these people. Can we change the way we train pharmacists? Let pharmacists decide during their undergraduate training where they want to work, and let them focus their internship along those lines. Number two, let internship be done under the supervision of the university as part of the training. This is very important. I know we have our own internship that is done after graduation. Now, this other one, we can actually change it into a residency or fellowship for people now to specialize further, gain advanced knowledge, and become specialists in those areas. And when you adopt residencies and fellowships, training will be devolved from the university to a local hospital, or from the university to the regulatory body, or to the factory where you're working. And this will make sure that pharmacists, once they leave school, they're able to continue working and building careers instead of taking study leaves to go back to school for 3 years. Because not every employer can give you a study leave, and not every employer can sponsor you to study. So a lot of us do need the opportunity to continue working, building our skills, and becoming good at what we do while still retaining our jobs. And another thing we can do about pharmacy training is that we should involve employers and alumni whenever we are reviewing the curricula. It is a basic principle of design that whenever you're designing a product or service, you must have the customer in mind. But universities have been doing their own things away from us and simply imposing things on us, and it doesn't work. We actually know how much of my time is spent on what aspect of my work. I actually know what I'm not good at because I was not trained in. So use us as a source of information on what really obtains in practice. Next. Now, I think it is time we paid more attention to industrial pharmacy. And there are two reasons for this. We need to create jobs. And number two, industrial pharmacy is going to be under attack. Once KDA bill is passed, you'll see all manner of people claiming a stake in the industrial pharmacy sector. In Kenya, we are lucky. We have managed to stop the onslaught for quite some time. We have delayed this onslaught, but eventually it will catch up with us. So we have to make sure that there are enough pharmacists who have skills in industrial pharmacy to occupy any position in the KDA authority, to occupy any position in the pharmaceutical industry. Number two, we need to industrialize as a country. And industrialization is important because we cannot always rely on imports. When products are manufactured in Kenya, we have a better opportunity to monitor their quality and to ensure that they're actually safe. And I think we are old enough as a country to have enough technology transfer into the country and start using these pharmacies to work in the pharmaceutical industry. The PPB has come up with like 3 different jobs for pharmacists in the pharmaceutical industry that would actually put pharmacists in charge. And I think we need more people to start thinking about industrial pharmacy. Maybe some of our universities in Kenya don't need to be doing undergraduate programs. They could actually set up postgraduate programs in many fields, including industrial pharmacy. And then another thing I think we can do in pharmacy training for Kenya, especially, and East Africa, is that we must adopt non-medical prescribing into the BPharm program and make it a key outcome of the BPharm program. That once you graduate, you're qualified to work as an independent non-medical prescriber. The other thing we can do is we must train pharmacists to create work. And one way you can create work is through the provision of consultancy services. So that mindset that I am here to advise people to do things, I'm here to help people make things happen, just like you're doing now with your network, it is something we should train people to do. And there's a lot of money that people can make through consultancy. Consultancy allows you to actually exercise your mind. And then I think finally, and this has been done in other countries like the US, you don't just admit people into pharmacy school because they applied or because they qualified. They have to show you that they have the passion to be good pharmacists. So we must have a selection process for who goes into pharmacy training. That would make a difference. Next. Now we have to think about how we can create jobs, right? So we can go back to the Pharmacy Practice Act. And I am happy that the Act assumes a very broad definition of pharmacy because you're basically saying anything that pharmacists do is pharmacy practice. So it starts from research and development to marketing, to distribution, to logistics, everywhere up to dispensing and drug administration. We are saying it's pharmacy. So this, when implemented, will create jobs for pharmacists. And I hope pharmacists will be ready to take up these jobs. The other thing that we need to think about as we are asking about how we can create jobs, because part of creating jobs is asking people to employ pharmacists. We need to have tools to measure the productivity of a pharmacist. It is not enough to say that you need so many pharmacists for a population X. That doesn't make sense. We must come up with other metrics to say, this is the workload of a pharmacist, and two, for you to know whether your pharmacist is productive or not, these are the things you should be able to do. These are the things you should be able to demonstrate. And we put it in writing, you know, and everybody is aware that when I hire a pharmacist, these are the things he'll do for me. Yeah. If we cannot do that, we are going to have a situation where pharmacists are fighting for jobs with technicians and employers cannot tell who why they should employ a pharmacist as opposed to a technician, because you have not really shown them what is this productivity that the pharmacist brings. And I think I'm unhappy with how people are doing these things. In some places, you see there are more pharmacists than farm techs. That is not right. Whenever you have more pharmacists than farm techs, the pharmacist will start doing the work that should be done by farm techs. It should be the other way around. It's a pyramid. Let's have more farm techs at the bottom and fewer pharmacists on top doing very select services, engaging in very select activities. And that will add value. And that will demonstrate the productivity of a pharmacist. Next. There is a big sector in my country. It's called procurement. Now, procurement is supposedly a profession regulated by another act. We simply have to amend that act to ensure that where medical procurement is concerned, we have pharmacists involved there. And there are many things they can do there. Pharmacists can advise the procurement committees on many things, including pre-qualification of vendors, tender evaluation, specification development. They can also do GDP audits, all right? And they can also go in and just review decisions made about procurement, medical procurement. If we create another role for pharmacists in medical procurement, we'll have taken charge of the whole chain, because currently there's a gap there where decisions about medical procurement are being made by certain other people. The people who now have control over what specifications go into the tender document. These are not pharmacists, and we should be concerned about that. It is an opportunity in which we can actually create more jobs for pharmacists. Next. Now, I think I've already said it. It is not enough to just focus on roles for pharmacists. We should actually be able to say what we are accountable for as pharmacists. What are people supposed to expect from? When I look at community pharmacy, I think the first work of community pharmacy is to make products available when and as required. I think that has been very bad, because I would expect that every pharmacy, as a minimum standard, you should have emergency medicines available. Anything required for resuscitation must be available. Okay, so we cannot have pharmacies where the pharmacist decides that there are certain items I don't want to stock for whatever reason. No, it should be all essential supplies are available as and when required. And when you are a pharmacist and something is out of stock, your work doesn't end there. Your work cannot end in saying this thing is out of stock. You must provide alternatives, solutions. When you're marketing products in Kenya, you're marketing snake venom, snake antivenin. You cannot just one day wake up and say, we are no longer interested in marketing that product in Africa. And that's it. The decision has been made in Paris. We are moving out. What happens to the patients? So as a pharmacist, you cannot be that person who communicates that kind of information. You must think through the consequences of the decisions you're making, because you are accountable for making the product available. Now, in community pharmacy or anywhere else, you are responsible for the quality of the product. Do not tell us that the PPB has looked at the quality. You are still responsible for ensuring that GDP has been maintained. When somebody brings you vaccines, can you confirm that they can actually demonstrate that the item was stored at 2 to 8 degrees during transit? I'm sure many people receive vaccines, lots of vaccines from very reputable vendors in Kenya. And the vaccines come in a carton and with a lot of ice packs. What temperatures were they exposed to? Who is accountable for that? Pharmacists have to be accountable for the quality of the products they're handling. Okay? You cannot be a community pharmacist and you're offering for sale dubious products. Strange things, blood purifiers, those Chinese products that do all manner of things. And some of you are even selling devices that diagnose 100 ailments through scanning and that kind of thing. We have to stop that. We cannot be doing things we cannot be accountable for. Now, then it's our accountability to ensure that patients are able to use the medicines well, that patients are using medicines they need, and only those that they need, and that patients are safe when they're using medicines, and that people are prescribing things correctly. We cannot be the people who will be allowing any kind of practitioner in town to write a prescription. Our law says a practitioner who can write a prescription is a vet surgeon, a medical practitioner, a dentist, or a clinical officer, but only for items they are allowed by their act to prescribe. If we start doing things the right way, the public will see that we are being accountable, and then we can start asking for other roles. But for now, we are yet to prove our accountability. There's one big threat facing pharmacy right now, the threat of counterfeits. We cannot be the people who report on counterfeits. We should be the people who solve that problem, because we are the pharmaceutical supply chain. We must ensure that there's integrity in the pharmaceutical supply chain. It is our role. We're accountable for that. The other thing we're accountable for is this thing called antimicrobial resistance. This is a big issue. We cannot just continue talking about it in the hospitals. The debate has to come to the community pharmacy, and we need to ask ourselves, as a profession, are we doing more harm or good to the public health? There was a time in history, and I can tell you this, when they were introducing antiretrovirals in Kenya. They said the antiretrovirals will only be distributed through a few hospitals, not every hospital. In Mombasa, there were just about 2 hospitals or 3 that were dispensing antiretrovirals. And it was just one combination of antiretrovirals from 2 different companies. But the companies convinced the board that it was in the best interest of the public to restrict them to those 2 or 3 hospitals. And it worked until we were able to set up systems to responsibly use ART. Now, I'm seeing a situation where somebody will one day wake up and say, we don't want antibiotics to be sold in pharmacies. Now, you see, when government comes up with policy, you don't tell them you shouldn't do it or you won't do it. You must offer them an alternative. You must demonstrate to government that as pharmacists, we have looked at this issue and these are the measures we put in place to contain this problem. So we are accountable for controlling antimicrobial resistance. The other thing we're accountable for is pharmaceutical waste disposal. Okay? We have to make sure that pharmaceutical waste is being disposed appropriately. So whether you work in a factory where you're actually discharging waste, think about the pharmaceutical waste. You work in a hospital, you're thinking about where you're going to incinerate. Are you sure your incinerator has the right temperatures to destroy the molecule? And if you're in the group that dumps into the environment, then you have a much bigger problem. As professionals, we have a value. I mean, we have a responsibility to humanity to make sure that pharmaceuticals are disposed appropriately, to ensure there's no diversion of expired stock and there's no harm to the environment or to the people who will encounter the waste. Now, the other thing we have to do, and it's related to this one, is we are accountable for ensuring that we are not generating waste. So as a pharmacist in a hospital, what is this you're doing about procurement to ensure that the list of expiry items, short expiry items, becomes shorter? Every time you are destroying medicines because they expired, you are spending money to destroy them. And you're losing the opportunity to use them. And all the work that has gone into procuring or even making the product or even testing it and certifying it goes to waste. So people have to do the right thing to ensure we limit pharmaceutical waste generation. We are accountable for that. Okay? We shouldn't let other people start talking about pharmaceutical waste. It should be us talking about it and addressing it. Now, we need to move faster. Another thing you can do to create demand for pharmacists is we can create, and PSK can lead in this, we can create centers of excellence. Centers of excellence means these are non-commercial centers that are set up to test all these models of practice, all these nice ideas about how to do pharmacy practice better. And they're well funded, and we can get people to come there to learn, to work part-time, gain the experience, learn how to do the right thing. And then when they go out there, they'll do the right thing. And I've already said we need to work closely with employers. And another thing we can do is we have traditionally been thinking that our allies are medicine. Maybe we should look for other allies as well if we want to be more effective. The nurses can be our allies. The clinical officers can be our allies. And even the guys who work in the lab, they can be our allies. We just need to think about it and start asking ourselves, what are the other possibilities? And then finally, whatever we do, we must always listen to the consumer. If you move too fast ahead of the consumer, you lose the consumer. If you move in a direction opposite to the one the consumer is moving in, you'll again lose the consumer. So we must always think about how we are communicating. And we must put to use the communication, the feedback we get from the consumer. What customers tell us, we should think about how we can use that information to improve our systems. Next. So we need to think about the future of pharmacy. We need to ask that question. Is pharmacy, community pharmacy, doing more good or more harm? If it's doing more harm than good, maybe it is time we say, okay, we don't need this. Let all community pharmacies be integrated to some hospital, some clinic, so that this idea that you're on your own and you do everything on your own and you're not accountable for anything stops. If we don't do it ourselves, somebody else will do it. Okay? Next. So I'm happy I was able to share this with you. I'm happy you've shown some interest in this. This is my contact, my email address, and you can look for me on Google Scholar, and you'll get to see the kind of other things I've written about, spoken about, or worked on. Thank you.
Thank you so much, Dr. Thank you so much. This has been very insightful, very informative. And I'm just looking at it and seeing what other possibilities do we have and what is the future of pharmacy for us. And one key thing is about the accountability aspect that you've talked about. I think there's a higher level of accountability that we need to ask ourselves, what is it that we're doing wherever we are to ensure that we guarantee the people who is benefiting from our services that there's no compromise that we are putting in the sense that the quality of care you're going to receive is what you've signed up for, what you expect of us, and actually meets what your needs are. I think that's a critical conversation that we need to have. And thank you so much for that. So I have another question, though, that is linked to the presentation that you talked about around the Social Health Act and Social Health Insurance Fund. This is a conversation that's picking up, and actually from the government directive is that it should be taking effect from July this year. So based on that, then when we look at the positioning of the pharmacists to be able to be empaneled and service providers that actually to be remunerated or reimbursed for the services, how do we drive that conversation? Is it PSK that should be leading that engagement that they discuss? And what would be the angle to be taken in making it a reality?
Wow. Okay. So, two things. There are many stakeholders in this issue. Okay. So you have to know that there are many stakeholders. It's not just pharmacists. There are the insurance companies also. And then there are patients. And then there are regulators. Okay. We cannot, if it's an opportunity that has been presented to us, we should take it. And the way policy is done is that politicians decide what is a priority. It's not professionals who decide. And you should always align yourself with the politicians. Whatever they're suggesting, just make sure your interests are taken care of. You should not be left out. But currently, we have to think harder about how we are going to position our people in that space. Because right now, we are less than 500 working in community pharmacy. So the rest of the people, who are they? We are unable to negotiate for very big things if we are not there. But if we say, this is a service, but it must be offered by a pharmacist, not a pharmacist or something else, pharmacist specifically, would be in a better position to say, okay, now we need to have pharmacists in community. We need to have a very clear strategy of what it is we want to. Other people are going to suggest things, right? So we must aim for very high standards. there has to be quality assurance in this. All right. But I think the opportunity we have is for us to introduce the debate on dispensing fees. This dispensing fee used to be there, but it used to be very small. Now it will have to be different. We have to say maybe it depends on how many items are on that prescription, or what is the complexity of the prescription, or what are the needs of the patient, or what category of patient that is going to be. So as pharmacists, we can come up with a very nice metrics of how to work out that dispensing fee. And then we push it to these people and we tell them, look, we are offering to lower the cost of medicine, but you have to compensate us for the service. It's a sacrifice we're making because we want to reclaim our profession. That 33% magic is what is drawing in so many people into pharmacy. Everybody wants to be in pharmacy because of that 33%. So we have to kill that 33% and replace it with something else. We just say, we are going to bring this item to you maybe at trade price plus 5%, and then we will charge for every service we give you relating to that medicine. So whether it's a quotation you want, whether it's a demonstration of how to use a device, whether it's a pharmaceutical audit, pharmaceutical review, we have to come up with those services because, you know, when you talk about lawyers, they have a file, they have a fee for opening a file. Can you imagine that?
Yeah.
Just opening the file, even without talking about anything, you pay a fee. Why can't we have similar things like that? Right?
Yes.
So we have to look at this whole proposal in a wholesome manner. That number one, I'm going to register people who will be my clients. So I'm negotiating on the basis of those clients. There are services I want to be doing for them from time to time. And I want SHIF to pay me for that. I think if the debate, the discussion is well thought of, we'll get somewhere. I think we need to involve the Ministry of Health. There's that part of Ministry of Health that is responsible for pharmacy standards. Also that part of the Ministry of Health that is responsible for public health. This is a public health issue. So if we come in, you know, public health is everybody, including community health workers. But frequently pharmacists are forgotten. This is the opportunity for us to start talking like public health people.
Totally agree with you on that, and that's commendable. And I think it's changing the conversation to see where is the value for us. And one key bit that you've mentioned is the aspect on the pricing, because even from a government perspective, there's been a lot of discourse around controlling medicines prices and all that, which is important because at the end of the day, then if I'm going to charge my service fee as a professional on the product that I'm selling, then I'll try as much as possible to give the product that will give me the highest margin in terms of cash over commercial value, which then compromises the value that I'm giving to the patient. And that is a conversation that needs to be had. Then we can cap the prices. And actually, we're doing some review on this in 2021. And I noticed in India, every product that is into the market has a price tag. The same way you go to a shop and you get Coca-Cola soda, it's written 33 shillings for the small bottle. That is how their medicines are. So if David goes to a pharmacy, then I'm a guarantee that I'm going to buy paracetamol. The paracetamol has 5 shillings on the label. That is the price that I should pay. Nothing more, nothing less. So then the professional services become a key argument in the sense that what is the value? And another bit that I love about the presentation is the aspect on accountability, because and when you're looking at it about accountability for the outcomes and the value that you're offering to the patient, I see you as a patient who I'm looking towards to ensure that they get better at the end of the day, rather than somebody is going to buy a product. Because at the moment, and when you looked about the quality metrics and the pharmaceutical service review, I'm asking myself from a regulatory lens, being a regulatory affairs person, currently we are talking about reliance. And in reliance, we're saying USFDA has reviewed product X and given an assessment report with the rationale upon which they made a decision either to register or not. If we could adopt such kind of a case where I treated a patient for malaria, I made the decision to use product A instead of B, guided by X, Y, and Z factors, then it means that information can guide the next person who is offering the service. And there's actually critical validation of the value of that technical service per the rationale in the quality service review, other than 2 times 3 and you're done with the patient at the end of the day. So what criteria does the patient even have to justify paying 1,000 or 2,000 shillings as consultation fee? You told them 2 times 3 and you left them to go home. I think this is a kind of a conversation, but also I'm asking myself, should these be led more on PSK side? And 2, if that is the case that we need to go through, how do we get PSK to be in tune on some of these perspectives and priorities that are coming up Because in a way, we've also seen some lacks both sides.
PSK is many people. PSK is not just one person.
For sure.
I think all of us have an opportunity to raise our concerns and to participate in the debate. Yeah, but we need to look at things from all perspectives. You know, policy making is a very, very intense thing. And it's not just a question of just bribing MPs to pass things. There are other people you can use to pass the message. I think as pharmacy, we have a habit of just engaging the media when there's a problem. We never engage them to tell them that there's something we are looking for. Yeah, so it should not be reactive. It should be proactive. And it should be an ongoing, ongoing
engagement. It's a
process.
relationship building.
Yeah, and then I think the other thing we have, and I think it's a Kenyan thing, we never really follow up on things we discuss. We discuss things and then we forget about them. We move on to the next thing. We have to be persistent in pursuing what we're asking for. Yeah, you can imagine since they stopped talking about the pharmacy practice bill, we haven't been talking about it ourselves.
Yeah,
I had to search the web quite hard to find it. I found a copy on the PSK website. Yes. But we should have been discussing this because the reason it was stopped was because of the KDA bill. Now that KDA bill is going in, the Pharmacy Practice Act will have to go in. Otherwise, there'll be a vacuum.
Yes.
So we have to be very strategic, but we have to remain focused.
And it is the investment in this process altogether. And I really, really appreciate that because I looked at it and I was saying, like, the pharmacy practice bill came alive in 2014, 2015, and the last submission to the parliament actually was in November 2014. But after that, there hasn't been any conversation. In 2020, it came back again. 2019 towards the end and early 2020, it came back again because there was the KFDA bill. Now, at that time, it was KFDA bill. Then after the conversation, we had like 2-3 stakeholder engagements. Then the whole wave of conversation went under. Towards the end of last year and early this year, with KDA coming back alive, the conversation is up again in certain circles and in different spaces. The question is, how many times do we want to have this back and forth? 2014 to date is 10 years. We're still talking about the same issues.
The problem is the politicians. Right now, the politicians are active in this thing because of UHC, because of manufacturing, industrialization.
Yes.
They use that excuse,
to start the conversation
to bring the issue alive. But the real issue is they're just interested in pharmacy business.
Of course. No, that is the truth.
They just want pharmacy business. That's all. Yeah, but of course they will package it as part of the debate on UHC, debate on manufacturing, industrialization. So if you want to get their audience, you have to align yourself with those, with that kind of framing.
That they're talking about, with the framing.
Yes, you have to work with them. You have to work with them. So it's a continuous thing. It's not enough to just make visits and tell them, don't vote for this, vote for that. It won't work. Yeah, you have to carry them along. So it's a long-term strategy.
It's a long-term strategy. Thank you so much for that. I think this has been a great conversation. I've actually picked a couple of points that I'm keen on engaging with some of the people within the space as well, and just to see what can we do, and maybe just to highlight some of the key things that I would be keen to follow through on is the aspect of the control of prices. Then when we control of the price factor, then can we introduce professional fee? And I would be keen to have a conversation with PSK to see, can we draft a charter that would cost for those prices? And also looking at the different variables on what LSK has done, the KMPDC has done, then that would give a framework. So then after, when we're talking about the pharmacy practice bill and act that will be passed, then can we have that as a provision that's already integrated into it? And we give the justification that these actually can help the government control on the cost of medicine, because the pricing has been an issue all through. So that would be a key winning strategy. And I think it could win on two fronts. On the other side, that there's the professional service of a pharmacist being recognized and being considered. But on the other end, if the price margins are not there on the product, then we'll actually deter the quacks and all the other people who are looking at getting into the business just for financial economic reasons. That would be a key bit, yes. Then on the pharmaceutical service review that are provided by pharmacists, I think there's need for us to work around that, but that would be from PPB, from the pharmacy practice side. Can we have these, maybe even if it's annual quality service reviews, where pharmacists, before you renew your license, if you're working in any sector, you're able to do a review of your services. and give perspective, because that would also inform the curriculum development, needs assessment for the government in regulation of practices. That would be a key contribution. Then the last bit is with the academic institutions, especially around training, internship, the preceptorship, and the fellowship component is important, because unless you're working under somebody who is practicing what needs to practice, you'll not get the value that you expect. So then the question is, after you're in the practice, how does that impact the quality of service you're offering to the people? Those are some of the key areas that I feel like there's room for us to drive it forward. And I'll be able to engage with these people. In case of any updates, I'll be able to reach out and share with you. Then we'll see what next phase can we come through. And I've really enjoyed this conversation. And thank you for writing as well. I've read some of the articles, and I'll keep engaging and seeing what we can do together for the profession and the industry altogether.
Thank you, David.
Thank you so much.
It was a pleasure talking to you.
It's been a pleasure.
Thank you
Have a
so
good
much.
one.
Thank you.